Good morning. I thank the organizers for the privilege of the podium. I'm going to be talking about a hybrid case to highlight how it can be used for multi-level CLI. I have no disclosures. So my patient is a 71-year-old male who presented with a 6-month history of a right great toe gangrene. He lives independently and ambulates short distances and has the usual comorbidities of hypertension, hyperlipidemia, diabetes, coronary artery disease, and a 50-year pack-year smoking history. On exam, he had a palpable left femoral pulse, but his right femoral pulse was not palpable, and the distal pulses were not palpable, though he had a monophasic signal in his PT. And he had dry gangrene of the tip of his right great toe and discoloration of a couple of other toes. On non-invasive studies, his ABI and toe pressure was 0 on the right side. He had a negative stress test. We did a vein mapping, which showed a good conduit on the left leg. The right leg vein had been harvested for his cabbage. We then did a CT scan, which showed that he had a patent aorta with a small aneurysm. His bilateral hypogastric arteries were diseased, and he had diffuse disease in his external iliacs on both sides. We then looked at the runoff, which showed diffuse common femoral disease, which extended to the profunda origin, and his SFA was occluded. His POP was diseased diffusely, and then he had a good PT that was reconstituting and running off to his foot dominantly. So we discussed treatment options in our team. The treatment options obviously are endovascular only, open surgery only, or hybrid approach. Fortunately, our center is participating in the BEST CLI trial, and so that decision was kind of made for us by the trial. So we enrolled him in the trial, and he got randomized to the open surgical arm. Now, obviously, he has inflow disease, so we had to decide how we were going to approach the inflow disease. And so we decided to do a hybrid approach where we did a right common femoral endarterectomy first with a profundoplasty that was quite extensive, going down to the second-order branches of the profunda. After that, we punctured the patch that we put on the common femoral artery and tried to get a retrograde access into the aorta. However, we were unsuccessful in doing that because we kept going subintimal. So then we decided to puncture the left common femoral artery. We put a catheter in his aorta, and we can see the severe left external iliac disease, as well as the diffuse disease in the right external iliac. So we went ahead and did a balloon angioplasty of the right external iliac, pre-dilated it, and then put a 7mm self-expanding stent. We also did an angiogram of the leg, which showed, after we did a common femoral to PT bypass, which showed a patent proximal anastomosis, a patent vein bypass, all the way to the distal anastomosis, and a good PT runoff to the foot. On postoperative day 1, he underwent hallux amputation. He was discharged home on postoperative day 3. He healed his hallux amputation well, and the bypass graft has done well and has been routinely scanned with duplexes. Currently, he's ambulating with no new wounds. So this case highlights the role of vascular interventionalists and the different approaches that should be taken to managing a complex patient with multi-level disease. Most patients with CLI should be offered revascularization and attempt at limb salvage. Endo and open surgery both have roles, and outcomes for both need to improve. And technical success is necessary, but that alone is not sufficient. Treatment failures have consequences, and optimal treatment strategy hinges on a rational, selective approach and a well-timed intervention. Treatment failures can result in both patient as well as hospital issues. Patients come back with delayed wound healing, recurrent wounds, increased tissue loss and infection. They have recurrent pain, immobilization, as well as psychological issues. It increases hospital costs, and also the family is negatively impacted by this. The correct procedure should be first picked based on the patient risk factors, limb stage, and the vascular anatomy. Time is tissue, and treatment failures are often poorly tolerated. The 2 trials that are now looking into the 2 approaches will hopefully give us answers on how to approach these patients, the best CLI, as well as the Basel II trial. Thank you very much.